طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على رسول الله الكريم سيدنا محمد وعلى آله وصحبه الطاهرين. سادة الحضور الكريم، السلام عليكم ورحمة الله وبركاته، وأسعد الله مساءكم وأوقاتكم بكل خير. تيسير الطيب حسن كاشف، مدير مركز الطبابة للتدريب المتقدم. I would like to thank all attendees for being with us tonight at the Tabab Hospitality and we wish you a good time. شكرا المهندس ريان بلة، مهندس تقنية المعلومات، والشكر للحبيب الأستاذ صلاح الدين الزبير سكرتير التدريب. الشكر الجزيل لأسرة الطبابة وممثلة فيه بروفيسور عماد صلاح. هو للأسف يعتذر في آخر لحظات ويبلغكم جميعكم التحايا، وخصوصا دكتورة غادة لظرف طارئ اضطر أن يعتذر هذه الليلة. والأب الروحي والقائد لمسيرة الطبابة. الشكر لكل أعضاء البورد والمؤسسين والإداريين، وتحية خاصة هذه المحاضرة لفضيلة أستاذنا دكتور طارق عوض، هو أحد أعضاء الطبابة وكان له يعني ما شاء الله هو حلقة الوصل واللينك، فجزاه الله عنا كل خير. We wish you a good time with tonight's session by Dr. Ghada Usman Abdurrahim, consultant in acute medicine at Queen's Hospital, United Kingdom. The objectives of this session tonight will be to explain the pathophysiology behind sepsis and septic shock and facilitate the recognition of early signs of sepsis and risk assessment for patients beside management of patients with sepsis. شكرا على زمنكم المقدر دكتورة غادة، ربنا يديك العافية. السادة الحضور الكريم, if you have any questions, please feel free after the session. Please make sure to mute your microphones when the session is started. At the end of the session, we'll give you a chance if you have any questions or comments. Hope you all enjoy. دكتورة غادة تفضلي مشكورة, your ground. تفضلي دكتورة غادة.
طيب، بسم الله الرحمن الرحيم. شكرا دكتور تيسير واهلا بالجميع. انا غادة عثمان عبد الرحيم، يعني الناس بيعرفوني بغادة حمور. consultant in acute medicine in Queen's Hospital في Romford, Essex, UK. I've chose this topic as sepsis is a really important condition that we frequently encounter almost on a daily basis in our clinical practice, especially physicians. But it is common also among other specialties. So I will start with a short presentation. This is a case, a lady whom I have seen last week in our acute assessment unit, an 8-year-old lady. 8-year-old lady. في زول قال هنا ما شايف البرزنتيشن، واضحة للجميع؟
بالنسبة لي واضحة هنا يا أبو سندر، واضحة.
البرزنتيشن واضحة.
أوكي. في أسماء أفتكر اسمها قالت ما شاف البرزنتيشن، نسيت ما قدرت أشوف الاسم كامل. An 8-year-old lady.
بس بيكون
admitted from ED to our medical assessment unit. And before proceeding, and I would like to explain these terms to those who are not practicing in UK. So a medical assessment unit is a medical unit which is run and serviced by acute physicians. It's meant to receive patients with various acute medical presentations presenting to the emergency department. And the management takes place in all medical conditions, all emergencies. We call it unselected medical presentations. We usually keep patients for 48 to 72 hours. And if they need further specialist medical input, we'll transfer them to other hospital wards. So this is where I work, in a medical assessment unit. So this is an 8-year-old lady admitted complaining of 2 weeks history of feeling generally unwell, shaky, feeling tired, and having reduced mobility. She felt cold intermittently, but there was no documented fever. Her past medical history including hypertension, breast cancer, for which she had a lumpectomy 25 years ago. She has been well since then. She has also high cholesterol. She's in amlodipine and simvastatin. She's a fit 8-year-old lady. She lives alone. She's really fit and well. She's totally dependent on herself. Sorry, independent. There is a missing thing here. Independent. Her daughter visits daily just to help a little bit, but she's usually fit and well lady. She never smoked and she drinks alcohol socially. On examination, I saw this lady with her granddaughter. The granddaughter was a staff, non-clinical staff in our hospital. She was really worried as her grandmother seems to be confused and more shaky since yesterday or the day before. So she expressed her concerns to me. She said her grandmother had a similar episode last year and was told she had urosepsis. She was treated as such. The patient herself was conscious and alert, but appeared confused. She was disorientated to place and person. She was unable to give a coherent history, so I had to rely on the history provided by the granddaughter. She was dehydrated clinically with dry mucous membranes and skin, flat JVP, no edema. She was in pale or jaundiced. Her chest and hearts were normal and abdomen were normal on examination, and central nervous system grossly did not show any obvious cranial nerves abnormalities, and no weakness on upper or lower limbs. Her blood pressure was 145 over 55, respiratory rate, pulse rate was 103 irregular, she's tachy. She had a temperature of 36.5, but in ED, in the emergency department, her temperature was recorded as 38.2. So she had a temperature earlier, she's tachypneic, she's tachycardic, and she's a bit confused and not quite herself. Some investigations, initial investigations, ECG shows sinus tachycardia. Blood counts, total blood counts was raised, 13,000 with neutrophilia of 11,000 and lymphocytes of 0.9. Urea was 9, creatinine 78, sodium potassium was normal, liver function tests were normal, and a CRP of 35. She had a venous blood gas done on arrival to the ED. Sorry, that's a blood gas is with us in the medical assessment unit. Just two parameters. Her pH was 7.4 and lactate was 1.6. She had a venous blood gas on admission to the ED, and her lactate was 2.1. So about 2 hours after admission, her lactate dropped down from 2.1 to 1.6. Her CT head showed no evidence of bleeding, infarction, or mass. And obviously, when an elderly person presents with a confusion, a CT head is needed. So that was done within the first hour of presentation. And we looked at her previous urine cultures in our system, which showed no growth, and chest X-ray showed no abnormal findings, grossly. So this is an elderly lady presenting confused, not usual herself, reduced mobility, without a clear clinical signs. We thought sepsis based on the previous history. The fact that she is unwell generally, the fact she had leukocytosis, her temperature, and we started treatment as per sepsis protocol. And within 2 days, the lady was well, back to her baseline. She needed another day of stay in hospital for a physiotherapy to help her with mobilization, and she was discharged home. So let's talk about sepsis. What's sepsis? By the end of this talk, hopefully, we would be able to define what's sepsis and septic shock. We would be able to recognize the signs of sepsis and septic shock. And hopefully you would be able to learn how to manage sepsis in the acute setting. When I say in the acute setting, I mean the second you receive the patient in the emergency department or within the first few hours, as for example in the acute assessment unit, like where I work. It's important to realize the signs of sepsis and septic shock early to provide complications. So task 1.
دكتورة غادة معلش المقاطعة sorry for interruption معلش يا شباب بس معلش يعني لأن الناس بتشتكي الناس بتاخد سناب شوتس دي بتعمل disturbance. المحاضرة ما دونت وري يعني هي مسجلة وحنرفع لكم في اليوتيوب وحنرسل لكم بليز في التليجرام جروب فدونت bother yourself. Enjoy the lecture just. Thank you.
طيب شكرا دكتور ياسين. Task 1. What is sepsis? Let's define sepsis. So sepsis is defined starting 2016 as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So you might know in the past we used to define something like SIRS, systemic inflammatory response syndrome. That was in the past used to define sepsis. And it used to define sepsis based on different physiological criteria: respiratory rate, blood pressure, temperature, change in mental status, blood glucose, and others. And we used to have within this a definition of severe sepsis and septic shock. In 2016, there was a publication of the third international consensus definition for sepsis and septic shock. And the definition adopted since then is it is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. And now we are focusing mainly on the outcome of the immune system dysregulation and its effect on the body, rather than defining sepsis by the physiological criteria. Okay, how do we define sepsis in reality? So there are 3 stages of this. The definition passed through 3 stages. Number 1 is the SOFA score, which is sequential sepsis-related organ failure assessment score. And if you can see, there are different criteria. So there is a respiratory rate. You give a score for PO2 over FiO2. So you give a score of 0, 1, 2, 3, 4, depending on the value. And then the platelets, 150, less than 150, less than 100, less than 50, less than 20. And then liver, bilirubin, cardiovascular, GCS score. And if you can imagine yourself seeing someone in the emergency department or the acute assessment unit and trying to assess or score the patient with sepsis, based on this, you will take an hour, because you need clinical variables, you need to have a look at the bloods, you need to compare these variables with previous readings. So it's really a complex scoring system that it's not used anymore. There is a much simplified score called Q-SOFA score, quick SOFA score, which relies on 4 parameters: respiratory rate, 22 or more, altered mentation, GCS less than 13, systolic blood pressure, 100 or less. This is a quick SOFA score. It's much less complex than the SOFA score, and its main use is in the intensive care unit. So we moved from SOFA score to quick SOFA score, and now in reality, we use something called, especially for those in UK, called NEWS2, which is National Early Warning Score 2, which is now more clinically applicable scoring system. So if you go back, for example, SOFA score, much complicated. Q-SOFA score, only 3 parameters, does not give the full picture of sepsis. The NEWS score now is widely used as a monitoring and defining score for patients with sepsis, and in fact with other clinical presentations. So we'll come to NEWS score later, but then I think by now we know what's the best scoring system. In the UK, it's NEWS2. In other countries, they might have a similar system. Let's talk a few points about sepsis. Sorry, septic shock. So we defined sepsis, now come to septic shock. Septic shock is a subset of sepsis, so as defined earlier, which is an organ dysfunction related to distorted immune response to infection. Septic shock is when you have this clinical picture, and on top of that, there are 2 changes. Number 1, persistent hypotension, requiring vasopressors to keep mean arterial pressure of 65 millimeters of mercury or more. And let's think about persistent. So we're not talking about initial reading of low blood pressure. So persistent hypotension after IV fluid resuscitation. So we have persistent hypotension, and we have a serum lactate that remains more than 2 millimole despite adequate fluid resuscitation. So now septic shock is sepsis, as defined before, plus these 2 new variables: persistent hypotension that requires the vasopressors to achieve a mean arterial pressure of 65 millimeters or more, and persistently raise serum lactate more than 2 millimole. In fact, septic shock is a condition with high mortality and is associated with profound circulatory and metabolic abnormalities. And ideally, if you see the patient before, if you see the patient who is not yet in septic shock, you should not allow him or her to arrive into this stage, because once the patient arrives at septic shock, it is a condition with high mortality and sometimes with irreversible damage, organ damage, if the patient survives. How common is sepsis? It's really common. Global incidence estimated as 19.4 million new cases annually of sepsis. So worldwide, we see about, let's say, about 20 million new cases of sepsis as are diagnosed, and there are 5.3 million sepsis-related deaths every year. So that tells us it's a quite common condition. In the UK, in 2017 and 2018, there were 186,000 hospital admissions for people with a primary diagnosis of sepsis. And it is present in many hospitalizations, which result in death. And in 2015, there were about 23,000 deaths in UK from sepsis. So it's a quite common condition. It is a treatable condition if recognized early, and it's a condition that is associated with high mortality if it's allowed to progress, especially to septic shock. If we are talking about what the organisms and which parts of the body are affected, we're talking about EPIC-2 study, and this is a huge study which EPIC stands for Extended Prevalence in Intensive Care Study. That was a huge study that looked into, or it's a prospective study that gathered data from more than 14,000 patients in ICUs from 75 countries within 1 day in May 2017. So it's a huge study. It was performed in 2007, and the results shown in this slide, although these study findings are related to ITU, we generally tend to find that these figures can be applied even to the medical wards or other general settings, hospital settings outside the ITU. So if you look at this slide, the lungs are most commonly affected. So we're talking about pneumonias here related to sepsis in 64% of patients, followed by abdominal sepsis. When we talk about abdominal sepsis, we talk about biliary sepsis, post-operative sepsis, for example, and then bloodstream sepsis, 15%, meaning especially sepsis related from infected lines, intravenous catheters, for example, and heart valves, endocarditis as well. Renal or genitourinary tract sepsis in 14% of cases, and although they represent only 14% of cases, this represents the most common site in elderly people above 65 years of age. So if you have an elderly person with a clinical signs, or you suspect sepsis and you cannot find a site, this is probably coming from the genitourinary tract. The most common microorganisms encountered are gram-negative, 62%, mainly Pseudomonas and E. coli, and 47% were positive staph, and about 20% were fungal. However, a definite source of infection after all investigations cannot be found in about 20 to 30% of people with sepsis. So you might do all the blood tests or the images you can do, and in a third of patients you don't reach into a conclusion of where is this sepsis coming from. Right. So this is the EPIC study, as just a small table explaining what we have said about the most common organisms. What's the pathophysiology of sepsis? How can sepsis affect the body? So that depends on 3 variables or 3 factors. Number 1, the type and resistance profile of infectious organism. So if you have a highly infectious microorganism, for example, like Pseudomonas, or resistant microorganisms, or fungi sometimes, especially if you have fungus in the bloodstream, that will lead to more profound effect on the body and more severe sepsis than when you have less resistant and less virulent microorganisms. Number 2, the site and the size of the infecting insult. So infections in deep tissues, infections where for example, abscesses that are less amenable to drainage or less easy to reach to, will lead to more morbidity and mortality. And number 3, the immune system of the patient, whether the patient has genetic predisposition to infection or acquired immune deficiency, that will lead to more severe effect of sepsis on the patients. How can the microorganisms produce their effect on the body? So we have gram-negative and gram-positive microorganisms. We said gram-negative microorganisms are more common than gram-positive, more common causative agent. And the first step is the binding of bacterial endotoxins. If we're talking about gram-negative bacteria, so they have an endotoxins which bind to the cell surface receptors. Gram-positive bacteria as well have cell wall materials that bind to the host immune system, as well as fungus. All these bacterial or microorganisms materials bind to receptors of the innate immune system of the body, mainly the neutrophils, the macrophages, and monocytes, and natural killer cells. This binding results in activation of a series of immune response and release of pro-inflammatory mediators such as interleukin and others, and resulting in tissue damage. And in sepsis, there is an exaggeration of the host immune response to these microorganisms. So it is magnified several times, which eventually results in collateral damage, tissue hypoxia, organ dysfunction, and at the end, it might lead to multi-organ damage. If severe, might lead to severe sepsis. So when you see a patient, as we said before, the effect of the microorganism depends on the immune system of the patient, depends on, let's go back, depends on the type of and resistance of the microorganism, the site and the size, and the immune system of the patients. There are subgroups of patients who are more vulnerable to infection, and when you see any patient, you need to risk stratify this patient, i.e. you need to think whether this patient is more prone to sepsis or not. Those who are more prone to sepsis, septic shock, and death from sepsis are those who are very old and very young, and we're talking about adults, we're talking about those above 75 years of age, especially those who are very frail. So they're more prone to develop complications. Those who have impaired immunity, diabetes, those who are on long-term steroids, those who are on chemotherapy, those who are on immunomodulating medications, patients who have a splenectomy in the past for various reasons, okay? Those who had surgery or any invasive procedure within the last 6 weeks, especially procedures in the esophagus or pancreas or the stomach, so they are more prone to have severe sepsis and septic shock. Those who have breached skin integrity, for example, those with burns, blisters of the skin, or infections of the skins. So they are more prone to develop cellulitis to start with, or simply this can act as a point of entry and they can disseminate widely in the blood, resulting in bacteremia and widespread infection in other parts remotely from the skin. Those who are IV drug abusers, those with indwelling lines or catheters, and we said before this is a high risk for bloodstream infection. Pregnant ladies, those who gave birth or who had abortion within the last 6 weeks as well, those who had prolonged rupture of membranes, and those who had a forceps delivery also are at increased risk of sepsis and septic shock. So when you see someone with a sepsis, ask yourself, does the patient belong to any one of those groups? If yes, that means he or she are more prone to develop complications. Right, think sepsis. When do we need to suspect sepsis? So, use your clinical sense, use your clinical judgment. Remember in the patient who came, the one I presented at the beginning, she did not show clinical signs of sepsis apart probably from a temperature, which can result from any cause, virus or anything. But the main issue was she wasn't behaving herself. She was confused. She has reduced mobility. Really non-specific signs and symptoms. Do not always wait for the profound signs and symptoms of sepsis to develop, to diagnose. So have a low threshold for suspicion, okay? The signs and symptoms are extremely variable and often non-specific. The key to improving the outcome is early recognition and prompt treatment, okay? By the time the diagnosis becomes obvious with multiple abnormal physiological parameters, the risk of mortality is really high. So think sepsis whenever there is something unexplainable, whenever there is something that doesn't fit, okay? Be aware that signs and symptoms are extremely variable and non-specific. Be aware of atypical presentations, non-localized symptoms, unwell patients with a normal temperature, just generally unwell, okay? Look for multi-organ dysfunction and shock, try to treat early, okay? When you see someone, think about the escalation status and limitations of treatment. This is really important from the start. If you see someone, you need to look at his baseline, look at the other comorbidities and decide how far are you going to intervene, how far are you going to treat, especially think about, does this patient needs an intensive care? Are you going to provide an intensive care or not? So think generally, use your clinical judgment. Whenever an ill patient presents with signs or symptoms of infection or high risk of infection, use a systemic approach to assess the risk of deterioration. Always assess his observations, heart rate, blood pressure, respiratory rate, hourly fluid balance, oxygen, okay? And remember, there is no diagnostic test that can tell you for sure that this is sepsis or this is not sepsis. So raised inflammatory markers is not an indication for sepsis alone. A temperature alone is not an indication for sepsis. It's the entire clinical picture that tells you this patient is septic and I need to act quickly before further deterioration. As we clinical assessment, stratify patients into high risk or low risk. Use your clinical judgment and use a validated scoring system, which we talked about before. In UK, we use the NEWS2, which is the National Early Warning Score in a patient with known or likely infection. And this score, a score of 5 or more, indicates sepsis. I will show you the score in a minute. A score of 7 or more indicates the need for a critical care specialist review. So this is the NEWS score. So different parameters. This is always recorded by nurses. And So respiratory rate, so you see the 0 in the middle here is the normal for all parameters. So respiratory rate, saturation is scale 1 and 2. So the oxygen saturation for normal people without previous respiratory problems. And this is scale 2 with patients, for example, with COPD or previous chronic respiratory problems. And we require a saturation of 88 to 92. And is the oxygenation is air or on oxygen, systolic blood pressure, and pulse, consciousness, and temperature. So the nurses will record all that, and on the deviation from the normal, they will score. So if someone has a respiratory rate of 21, score 21, it will score 2, for example. If his blood pressure is less than 90, he will score 3. And then 3 and 2, 5, they will alert the clinician, for example. Or any combination of other parameters. So this is the standard monitoring for patients currently in UK. This is how the nurses will respond. Trigger and treat. So if you have a score of 0 to 4, this is a low risk. So this is a ward-based response. If you have a red score, 3, so this is low medium, urgent ward-based response, which means response by a clinician or a team with a competence in assessment and treatment of acutely ill patients, and in recognizing when the escalation of care is appropriate. So this is done by the nurses. So usually when they say this patient is using high, is using 3, they will call us to review the patient. If 5 to 6, this is medium, and this is where we suspect sepsis if someone has no other diagnosis. So the nurses might just alert us. 7 or more is high, and that should trigger an intensive care review if someone is already decided that he should go to the intensive care. Okay, and this score is not only used for sepsis, it's used for monitoring patients who are as an inpatients with other medical conditions. If we diagnose the patient with sepsis already, what to do next? This is the golden hour, the 1 hour rule in any patient who presents with sepsis. Step 1, establish a venous access early so you can do whatever you want. You can proceed without delay. You see the patients, you insert a cannula. Okay, within 1 hour, you need to give blood spectrum intravenous antibiotics, broad spectrum. So this is if you don't have any idea about the likely site of the infection. So if you have by this time a clinical impression of a site of infection, then you narrow the choice of IV antibiotics. For example, this is likely pneumonia based on the history and clinical examination, even if you don't have a chest X-ray, for example. Recent urine sepsis, urine cultures, and you suspect urine sepsis, you give an antibiotics which are directed against that site of infection. And at all times, use your local guidelines, local microbiology guidelines, because the prevalence and resistance of microorganisms, and we're talking about bacteria here, differ between different sites. If you don't know, then broad spectrum intravenous antibiotics, and always be guided by the microbiology advice. So give antibiotics, give fluids, and if the patient is showing any sign of circulatory insufficiency, that needs to be given immediately. This is just an estimate, so the guidelines tell us to give about 3 to 5 ml per kg body weight within the first 2 hours. In someone who is an average of 70, that means about 2 to 2.5 liters of fluid within 2 hours, provided that the patient is not known to have heart failure or other conditions that prevent us from giving enough IV fluid. Okay, so usually we give 500 ml start and then reassess the response, and then we give more if needed. Let's remember, it's variable, depends on the degree of hypovolemia of the patient, depends on the response to the patient. Number 3, give oxygen is needed. Okay, so within the first hour, you should give IV antibiotics, fluids, and oxygen is needed. This is essential to be given within 1 hour. And we're talking 1 hour, 1 hour from presentation to the hospital, from point 0, which means from the second you decided that this patient is likely having sepsis. So within 1 hour, give antibiotics, give fluids, give oxygen. And within that hour, take blood cultures, ideally 2 sets of blood cultures. Okay, so if the blood culture is going to be delayed, do not delay the antibiotics in order to take samples. So ideally, the blood culture should be taken before antibiotics. But if there is any delay for any reason, you should give the antibiotics and do not wait for the blood cultures to be taken. Okay, so this is the first hour rule. Take blood cultures, give antibiotics, give fluids, and give oxygen is needed. Okay, and then think. This is a demonstration from Surviving Sepsis campaign. The first hour rule is called 1 hour bundle. So time 0 is the time of presentation. Okay, so the time of in the ED when you said this is you made a diagnosis of sepsis of septic shock, that's time 0. So number 1, this is a lactate. Well, I find that's within hours as well, but the most important thing is the blood cultures. Number 2, obtain blood cultures before giving antibiotics. Number 3, broad spectrum antibiotics. And we said if you have a likelihood of a site of infection, narrow the antibiotics choice, don't give a broad spectrum antibiotics. Okay, if the patient does not respond to, begin fluid, 30 ml per kg of IV fluid. Okay, and number 5, if there is no response, apply vasopressors. Okay, if hypotensive, or if after fluid resuscitation the lactates continue to be more than 4, you need to give to keep arterial pressure above 65 or 65 and above. That means the patient is in septic shock. You need to apply vasopressors. But don't forget the cultures, the fluids, the antibiotics, the oxygen, and it's always useful to measure lactate, because persistence of lactate level above 2 millimole despite IV fluid is a sign of septic shock. This is the Sepsis 6, which is widely applied in UK, and I'm sure it's applied elsewhere. So the 6 measures that you need to make sure done: give oxygen, take blood cultures, give antibiotics, give fluid challenge, measure serum lactate, and measure urine output. That's an additional one. So gradually, you do things. You assess patients, sepsis, take bloods, administer fluid, administer antibiotics, give oxygen if needed, measure urine output, okay, as a measurement of the volumic state of the patient. Sometimes you might need to pass a urine catheter. Okay. Additional things, in addition to the basal things, if the line infection is suspected, if the patient has a catheter, for example, Hickman line or anything like this, or a central line, remove the line and culture the tip if you can. Okay. Other blood tests, full blood counts, urea and electrolytes gives you an idea about whether the patient is hypovolemic, is he in acute kidney injury or not. Liver function test, CRP as an inflammatory marker, okay, ECG, urine for culture and sensitivity as well if you are suspecting urosepsis, joint fluid if you are suspecting arthritis, for example, an infected joint as a cause of sepsis. But this all will come after the first resuscitation measures mentioned above. Okay, then you can do an imaging, attempt to identify the source of infection. As we said, most common site of infection is the chest, so pneumonia, chest X-ray. But sometimes you need abdominal images, abdominal CTs, if you are suspecting, for example, collection, if the patient is post-operative. Other things need to be considered. So it depends on the clinical presentation, really. Notes are coming, and يا شباب تعرفين الكومنتس اللي بتجي دي قاعد تجي في البرزنتيشن حقتي أنا ما عارفة. خلاص روحتها. Okay. Other examples from other sites, if the patient is having ascites, for example, you suspect spontaneous bacterial peritonitis, you take an acidic sample, pleural fluid, you are suspecting an infected pleural space, empyema, you take a pleural fluid sample, you send for cultures, always send for cultures. Wound swabs, send for cultures, okay, operation sites, send for analysis and culture, please. Right. How to monitor? So you saw the patient, you assessed, you gave antibiotics, you gave fluids, you gave oxygen, you measured lactate, okay, and you pass a catheter if the patient is in need, just to monitor urine. You don't need to pass a catheter urine catheter in all patients, but you might need if the patient is unable to, for example, is oliguric or you cannot measure the urine output. You can pass a catheter. How to monitor? Clinical follow-up, repeat observations depending on the clinical features. So if the patient is clearly unwell, sweaty, clammy, he's still shocked, you will do more frequent check of observations or vital signs. If the patient is stable and the initial observations are within normal, then you can space the observations. So it's a clinical judgment depending on the clinical condition of the patient. Hourly urine output, that's important. That's part of the monitoring of the patient because it indicates the intravascular volumic state. So if it's low, that might indicate that the patient will need more fluid if he can take, if he's not a patient with heart failure, for example. Okay. Monitor lactate level. If the lactate is more than 2 initially, so repeat the venous blood gas after giving adequate fluids. I would suggest after giving at least 2 liters and then repeat. Okay. After you do what you think is adequate, you give adequate fluid and the patient is clinically not hypovolemic anymore, as you assess him clinically and by urine output and general condition of the patient, but the patient is still unwell, he's not responding, he's oliguric, okay, he remained hypotensive despite adequate fluid resuscitation, his lactate is persistently above 2, then it's probably time to call intensive care to take over, because this patient might need vasopressor support, he might need further management if he develops other organ failures, which can better be provided in the ITU. The aim of the previous management is to try to avoid reaching to this stage where you transfer the patient to the ITU, if we can. So this is the management. Complications of sepsis, sometimes, no matter what, you do whatever you can and the patient will not improve and will develop complications, especially if it's late presentation or if the patient is already immunocompromised or an elderly frail patient. So the patient might develop complications. For example, first one is hypotension, which is mainly caused by volume depletion. So the volume depletion might be related to reduced oral intake. If an elderly patient might be living alone, not having enough, he has been unwell for a few days and therefore not drinking well, increased venous capacitance, increased fluid loss due to high temperature, due to tachypnea, due to capillary leakage. We know in sepsis there is venodilatation and capillary leakage, and fluid will go into extravascular spaces, leading to intravascular hypovolemia. So all these reasons might, all these causes might lead to volume depletion and hypotension. Usually, this is reversed by adequate fluid resuscitation. However, sometimes persistent hypotension happens, and it's usually due to a combination of low systemic vascular resistance, hypovolemia, and myocardial failure resulting from reduced cardiac output as a result of severe sepsis simply. Okay, sometimes if you put a patient on a ventilator and he's on PEEP or something, that might lead to hypotension as well. Acidosis as well results in venodilatation, vasodilatation, and hypotension. So that's hypotension. Number 2, acute renal failure. We commonly see oliguria in hypotension, but it's in patients with sepsis, but it's usually reversible with adequate fluid resuscitation, but anuria is rare. Okay, but oliguria is common, especially if you give adequate fluid resuscitation. Another common condition is AKI, or acute kidney injury, which is manifested in increasing creatinine anuria, and we all know the definition of acute kidney injury, but it's usually not associated with histological or pathological changes in the kidney itself, and usually does not need any long-term renal replacement therapy. Okay, so for the kidney, hypotension might lead to transient oliguria. If not treated well, it might lead to anuria, and it might lead sometimes to acute kidney injury. In severe cases, especially in septic shock, might lead to acute kidney failure and the need for a renal replacement therapy in the intensive care. Acute respiratory distress syndrome is also another complication of sepsis, and it's especially a complication with high mortality. It does progress quickly, and initially it might be manifested just by tachypnea, respiratory rate more than 30 with a normal arterial oxygen levels. So if you have a patient with sepsis who remain tachypnic with a respiratory rate above 30, you need to be careful, because that patient eventually might get tired, fatigued, and go into respiratory failure and might need intubation and mechanical ventilation. Okay, if someone develops acute respiratory distress syndrome and he goes into intubation and mechanical ventilation, and I'm sorry, I don't have time for ITU management of this, but we know it is low volume mechanical ventilation, and other details are not to be mentioned here because of time limitations. Okay, it might improve after extubation, or it might result in lung fibrosis with persistent hypoxemia, and we have seen patients being discharged on oxygen after long time ventilation because of ARDS resulting from sepsis. DIC, disseminated intravascular coagulation, a well-known complication of sepsis, results in bleeding into the skin and subcutaneous tissues and mucous membrane, together with some occlusion of blood vessels caused by fibrin in the microcirculation. So it's a combination of occluded blood vessels and bleeding, complex management, essentially the treatment of underlying disease, which is sepsis, and blood products to control bleeding. Okay, always involve others. If you are an acute physician or general physician, always involve the hematologist, always involve the kidney physicians, always involve other specialties if you need their input. Myocardial infarction and dysfunction and failure, it's rare. We know there are myocardial toxicities resulting from sepsis, but pure myocardial failure is rare following sepsis, and it should usually be prevented by adequate filling pressures through IV fluids. If not, then inotropic agents. But we don't see heart failure commonly as a result of failure, as a result of sepsis. Hepatic encephalopathy, liver failure as well. Liver dysfunction resulting from liver ischemia, an effect of acidosis in the liver, and the accumulation of toxic products in the bloodstream, mainly produced by bacteria, resulting in hepatic encephalopathy. okay, and especially in those who already have chronic liver disease. And the management, as you probably should know, laxatives, prevent GI bleeding, okay, avoiding sedatives. And the only difference here is like we should not give a low protein diet. It's not advocated here because these patients are already malnourished with muscle wasting if they have severe sepsis. So we don't advocate low protein diet. Neurological complications occur in up to 30% of patients with bacterial meningitis, but other sepsis sites, for example, pneumonias and neurosepsis, do not lead to focal neurological signs. They might result in generalized reduction in conscious level, which should improve after treatment. If patient develops multi-organ failure, they might develop polyneuropathy, and that might increase by the use of neuromuscular blocking agents during intubation and mechanical ventilation. Finally, multiple organ failure. So if you have severe sepsis and that did not respond to early adequate treatment of sepsis, it might result in multiple organ failure. Each one organ failure increases the mortality by 15 to 20%. So each body organ failure increases the mortality by 15 to 20%, and therefore, imagine if you have more than one body organ failure, that means probably 75% chance of death. And as we mentioned before, lung dysfunction tends to occur early and persist. And as we mentioned before, it's probably manifested by tachypnea early before we get the hypoxia on blood gases. So if tachypneic patients, keep an eye, just double check whether this patient is developing an ARDS or not. CNS and liver functions tend to happen late. Treatment is primarily supportive, so treatment of sepsis as antibiotics, and then goal-directed therapy, so treatment of anemia, treatment of coagulopathy, treatment of shock, and standard ITU care like a ventilation, dialysis or renal replacement therapy for someone who developed renal failure, ventilatory support for someone who developed acute respiratory distress syndrome and respiratory failure, okay? Sedation, agitated patient. This is an end result which should not happen if the patient presents and managed early. So I think I'm approaching the end of my presentation, and the message I would like you to take from this, the take-home message, as we said previously, you need to recognize early the signs and symptoms of sepsis. You need to recognize that sometimes the patients do not present typically with temperature and clear signs of infections. Sometimes there might be non-localizing, non-specific symptoms, especially in elderly or immunocompromised patients. We need to rely on our clinical judgment to diagnose sepsis, and we need to act early. We need to decide how far are we going to go in our management, depending on the background of the patient and the likelihood of response. We need to keep an eye on the patient and monitor him and decide when do we need to involve the intensive care unit, okay? Don't forget the golden rule, the golden hour. Take blood cultures, take venous lactate, give fluids, give antibiotics, give oxygen if needed, reassess, check urine output, check the observations, okay? Recheck lactate after adequate IV fluids. If hypotensive or lactate remains 2 or more, think of intensive care. Thank you so much. I hope that was helpful.
شكرا جزيلا دكتور غادة، كتر خيرك for this nice presentation. طيب لو في أي حد عنده سؤال أو مداخلة تفضل. نفتح باب الأسئلة إذا في أي زول عنده سؤال ولا استفسار.
السلام عليكم، ممكن أسأل؟
السلام، تفضل.
السلام.
أيوة. شكرا لك. Thank you very much, Dr. Ghada, for the excellent talk. My question is about, you mentioned about giving fluids. How far you can go with the fluids before you worry about fluid overloaded for the patient? Thank you.
Okay, so it depends on the clinical background of the patient. So if the patient is known to you to have heart failure with with an ejection fraction of 20%, you need to be cautious. So if the patient is already exhibiting signs of fluid overload, he's in heart failure. Let's not forget, someone might be in heart failure and might be septic, and it's really a dilemma. So if someone is already showing signs of heart failure, in practice, and I'm just talking about our practice, which, and I think others might agree with me, you really need to be careful. Give very small amounts of fluids, 200, 250 ml, and reassess. Is the patient improving or not? And assess for signs of overload. Okay, we need to think about the patient who is in heart failure with an ejection fraction of 25%, and need to think what's the optimal blood pressure for him or her. So if someone with an ejection fraction of 20%, systolic blood pressure of 90 might be usual for him, provided that he is well perfused, he does not show signs of peripheral hypoperfusion, cold skin, for example, capillary refill not prolonged. Okay, if that patient is not showing signs of peripheral shutdown, probably a systolic blood pressure of 90, for example, is okay. And it's always better to review the previous readings, and it's always better to look at the nose previously if you have, and to see what's the usual blood pressure, because we shouldn't push for fluid to reach 120 systolic pressure in that patient, and it might be harmful. If you don't know the situation, if clinically the patient is in heart failure, again, I will give very small amount, 200, 250, and reassess. If the patient is showing sign of overload, he started to deteriorate, I will stop, and I might arrange a critical care or high dependency unit review, because this is a dilemma, because you can't give more fluid. The patient might need inotropic support, might need more invasive measures of his blood pressure, which is not usually done in the usual medical ward. However, if the patient is not showing signs of heart failure or any signs of other hypervolemic states, we aim to give up to 2 liters in the first. So we said before 30 to 50 ml per kg in the first 2 hours in a 70 kg patient, so like an average adult who is 60 to 70, so 30 by 70, that means 2,100. So between 200, 2 and 2.5 liters up to 3 liters within 2 or 3 hours. That's our practice. Ideally, what we do, we give 500 ml initially. We see the response. If there is no response, we prescribe more, but we aim to give 2 liters within 2 hours minimum. If there is no response, we consider that the patient is not responding and might need to involve others. It's not only the blood pressure, so you check the blood pressure, check the urine output. Okay, is that enough, or do you think that's clear, or do you need more clarification? Hello?
Thank you. Very, very clear. Thank you so much.
Very clear. Okay. I think in my presentation I said.
شكرا دكتور غادة. في عندنا سؤال ثاني؟
فكر just if you are going to keep it, it's 20 not 2. في معلش في I'm waiting for answers but I'm just
طيب في سؤال دكتورة، عندنا سؤال دكتورة غادة.
أيوة.
نعم.
تفضل.
What is the best inotropic agent? Pardon?
So as I said, this topic is not for
عندنا سؤال في comments. What
intensive
is the best
care.
inotropic agent?
This is
مريم
not,
تسأل.
okay, this is not the talk I gave is about the stage before intensive care, trying to avoid intensive care, but the practice is noradrenaline is the one which is usually used if we need to start with, if all our measures fail. That's the best one. I think we need to, we might have another lecture from an intensivist. That would be ideal.
Any other comment?
Can I ask another question, Dr. Ghada?
Of course.
Okay. Now in the era of COVID-19.
Say that again in early.
In the era of the COVID-19, usually we get mixed message about do we need to give people fluids or we should keep them dry for the lung. So what's your experience in that area?
Yes.
How should we approach? Thank you.
Yes, that's really a good question. It depends on what you think the presentation is. So we have been told initially to keep the patient dry. That's when, so when we first saw patients with COVID-19, we used to give them more fluid. Then after a few weeks, we have been told, no, keep them dry. And then a couple of weeks later, we have been told, no, keep them euvolemic, keep the urea in the upper limit of normal. It depends on whether you think the sepsis is coming from the COVID. And if you are here, we're talking about pneumonia mainly and complications. So whether you think this is coming from COVID or this is non-COVID. The COVID is recognized by X-ray changes, basal, bilateral infiltrates, typical fluffy viral looking pneumonia. So bilateral, mainly basal, starts basal and spreads. It's bilateral. And temperature and raised inflammatory markers, raised D-dimer, okay, and lymphopenia. These are really characteristics, especially the lymphopenia. If we see someone with a likely COVID and sepsis related with COVID, and I'm talking about still the stage before the ITU, because in the ITU, the whole scenario is different. In the medical ward, or in the acute medical assessment unit, where we treat patients who are still manageable with fluids, who are still manageable with oxygen, nasal cannula, face mask, non-rebreathing, those before the non-invasive ventilation, those before the inotropes. So in this stage, if it's COVID, keep them euvolemic. And that's mainly, is purely a clinical examination criteria and decision. So don't give much fluid. Sometimes we don't give fluid at all, or we give only 1 liter within 24 hours. Just give the maintenance. So if you think this is COVID based on the X-ray changes, the blood tests, then keep euvolemic. If this is not COVID, so if it's pneumonia, for example, if there is leukocytosis, neutrophilia, if there are multilobar involvements, this is more likely bacterial, non-COVID pneumonia. And in this case, we treat them along the lines I have just mentioned in my presentation. And you always need to involve others, intensive care early if it's COVID, because COVID, they just go downhill within hours. But when it comes to fluid, COVID, euvolemic, non-COVID, pneumonia, other sepsis, as I said in my presentation. Okay.
I have a question.
دكتور غادة.
Can I ask?
تفضل. Yes.
تفضل.
شكرا جزيلا على النايس برزنتيشن. بسأل any rule for BBI for protect from stress ulcers such patient who are very ill or liable to get sepsis?
No, it's not part of the management. PPIs are not part of the management of sepsis. They are not. They are given usually if someone has extended hospital stays and if they have other medications, for example, that might predispose them to having stress ulcers, but they are not part of the management of sepsis, especially we're talking about the initial stages, ED and after admission, first 24 to 48 hours. Yeah.
Great, thanks for you.
Okay, you're welcome.
Do you have any more questions?
السلام
في سؤال ثاني
عليكم.
يا شباب أو مداخلة؟
شكرا جزيلا.
السلام.
أيوة. It was really a very comprehensive session. And my question is, what is the mechanism behind the acute kidney injury in sepsis and the management? Thank you.
The mechanism behind acute kidney injury is hypovolemia. So if you have hypovolemia, and especially if it's persistent hypovolemia leading to persistent hypotension, you have less renal perfusion, you have less blood going to glomeruli, and that might result in glomerular damage and acute kidney injury. It's primarily hypovolemia related and hypotension related. And prevent it, fluid resuscitation is the most important thing in the management. It's the most important preventive measures to prevent acute kidney injury. Give adequate fluid, measure urine output. The urine output is a good measure of the kidney function. And in turn, this is a good, the kidney function, the good kidney function is a good measure of the volumic status of the body as a whole. So that's why part of the monitoring of patient with sepsis is hourly urine output, either just measure, ask the patient to give urine, or passing catheters if the patient is unwell. So it's hypovolemia. That's why you keep saying in the first hour, give fluid, give fluid, give fluid, give antibiotics, and give fluids. And in fact, when we say measure lactate initially, and then after some time, if it's high, the only intervention that will bring the lactate down is fluids. Because the lactate is a measure of tissue hypoxia. The tissue hypoxia results from hypotension. So if you give fluid, that will resolve the hypotension, adequate fluid, resolve hypotension, ensures no tissue hypoxia, and ensures that lactate is coming down. So if the lactate is coming down, if it remains below 2, that's a good sign that you are giving adequate fluid resuscitation. Okay, and prevent kidney injury, give fluid, please. Okay.
يا دكتورة عندي سؤال ثاني ممكن أسأله؟
اتفضل يا دكتور، اتفضل.
يا دكتورة.
أهلا.
What is the best antibiotic from your experience? You said you must have a lot broad spectrum antibiotic. يعني صراحة هم الكتار يشتغلوا ناس فوق ناس سيفتيزيم سيفترايزون.
Okay. As I said, إحنا
يعني from your experience.
Yeah, I know. لا ما فيها experience. شوف إحنا بالسودان is different. I have worked in Sudan for years and years. The ideal situation is to go by your guidelines. As I said before, the prevalence of microorganisms differ between different hospitals, different areas, there is the pattern of bacterial resistance, and we're talking bacteria here because they are the most common cause of sepsis here. So mostly bacteria followed by fungi and less by viruses. So the prevalence of bacteria differ. The resistance of bacteria, the pattern of resistance is different between different areas. So, for example, here in UK, you have guidelines, antibiotic guidelines for different infections. So if you are suspecting pneumonia, for example, you classify pneumonia, CARB 65, mild, moderate, severe, and with each category there is a guideline telling you what to do. And these antibiotics guidelines are derived from the local experience, from the local microbiology of that hospital or that area. If you move to a different hospital, you will find a different antibiotic choice. For urine, again, it's different between different hospitals. Generally, if I'm speaking generally, for chest infections, if you want to give monotherapy, for example, like CARB score 1 might be amoxicillin, CARB score 2 might be coamoxiclav, CARB score 3 coamoxiclav plus clarithromycin, because you need to cover the typical. But that's general talk. It might be different from different countries. They don't use cephalosporins in UK very often. They rely on penicillin. So, for example, I know we used to give ceftriaxone plus clarithromycin for pneumonia. That's not used here. They used amoxicillin or coamoxiclav plus clarithromycin. For urine, the most commonly used, if you are suspecting urosepsis, are amoxicillin plus gentamicin. Other hospitals use amoxicillin or coamoxiclav plus amikacin. That's a general talk. For biliary sepsis, for example, someone who has a biliary obstruction or biliary disease and develops sepsis or cholangitis, it's usually a combination of cotrimoxazole, coamoxiclav, with or without aminoglycosides. But it's different. That's just a general idea. But it's different. The practice is different. Depends on the local guidelines. And CNS, for example, meningitis. Meningitis, I think it's the same everywhere. It's ceftriaxone, for example.
Oh.
Everyone gives ceftriaxone, and if it's encephalitis, it's acyclovir. Joint infection as well is, I think, it's ceftriaxone. This is where I work. But everyone checks the antibiotic guidelines of the hospital here.
Okay, thank you very much, doctor.
You're welcome. Can I say something? الدكتورة سألت عن how to avoid acute kidney injury. Okay, so I said fluids and management, and also avoid nephrotoxic drugs. يعني if the patient comes in sepsis and he already has or she has an acute kidney injury, don't make it worse by giving nephrotoxic drugs. So if the patient is already on angiotensin converting enzyme inhibitors, angiotensin receptor blockers, diuretics, for example, you stop them, especially because the patient will not be hypertensive. So in addition to fluid resuscitation, avoid nephrotoxic medications, okay? Antibiotics like gentamicin and amikacin are nephrotoxic, so we need to be careful and give them in appropriate doses. Avoid nephrotoxic medications as well on top of the IV fluid and antibiotics. Yeah.
طيب شكرا دكتورة غادة. في سؤال من دكتورة عصماء: when to give steroids in patient with sepsis. في سؤال مشابه: any role for hydrocortisone small doses?
No, so in sepsis, pure sepsis, there isn't. The role, as we said, fluids, antibiotics, monitoring. Okay. If conditions become really worse, unmanageable, the patient goes to the ITU, intubated, ventilated on inotropes. Sometimes, as a last resort, they give antibiotics for steroids for septic shock. But For us in the medical ward, acute assessment unit, when we see the patient and we can still manage with antibiotics before the stage of, with IV fluids and antibiotics and oxygen, before we call the intensive care, there is no role at all of steroids in the management of sepsis.
Steroids.
One condition you might consider it, if someone who's known to have, who's known to be on steroids for a long time, okay, for any disease, we know some people with chronic medical conditions might be on steroids, and they'll present in sepsis or septic shock. In this case, you might need to increase the dose of the steroids, but that's only because the patient is already in steroids, in long-term steroids. If you know, or if you have a suspicion sometimes that the patient might have been on steroids and this is an adrenal insufficiency or adrenal crisis, yes, again, you might give steroids, you might give IV hydrocortisone, okay? But only if there is an element of adrenal insufficiency, either history-wise or clinical picture suggesting this. But otherwise, you shouldn't give steroids.
Okay, thank you. Last question من دكتورة فاطمة عبيد. Is there any role of immunoglobulin in sepsis management?
Immunoglobulins?
Yeah.
I'm not aware of this. No, immunoglobulins. Let me think. No, there isn't. Immunoglobulins are, why do we give for infections? So sepsis, is, as we said, is a disordered immune response to infectious agents. And I can't see why we need to give immunoglobulins. I can't think of a condition that we need to give immunoglobulins. I'm not sure. No, we don't use it in acute sepsis.
Okay. Okay. Thank you so much, Dr. Ghada. So message to take home: early recognition, and you have to rely on our clinical judgment, as not all cases present with clinical or with typical picture, and we have to remember the golden hour rule. دكتورة غادة كتر خيرك، شكرا جزيلا، ممنونين جدا لوجودك، ودارين منك وعد ان شاء الله بمحاضرة ثانية بإذن الله تعالى لما ظروفك تسمح لك ان شاء الله.
Inshallah, I will be happy, and I would suggest to call an intensive visit عشان يكلمكم عن septic shock management. I'm not sure if I know someone,
okay.
But that will be useful as well. شكرا جزيلا. Thank you very much for everyone. My pleasure. Hopefully I was clear and useful in this presentation.
شكرا يا دكتورة غادة، كتر خيرك، ما عدمناك ان شاء الله، يديك الصحة والعافية. شكرا السادة الحضور الكريم، عطرتم ليلتنا هذه المساء، والى الملتقى ان شاء الله. شكرا جزيلا، السلام عليكم ورحمة الله وبركاته. شكرا دكتورة غادة، كتر خيرك.
السلام.
عليكم السلام ان شاء الله.